Hello, I'm Erin Cox, physiotherapist, and today we're going to talk about elbow anatomy. So first of all, what is the elbow? We talk about the elbow complex because it involves three joints: the ulnohumeral joint, the radiohumeral joint, and the superior radial ulnar joint. You'll see I put HU and HR because depending which literature you read, sometimes it's referred to as the humeral ulnar or the humeral radial. Point is, it's between the ulna and the humerus, or between the radius and the humerus. So let's do a little bone anatomy review. This is the lateral epicondyle. This is the medial epicondyle. This, the capitulum. This one, the trochlea. And here, the head of the radius. And finally, on the anterior part, the coronoid process. On the posterior surface, we have the olecranon and the olecranon fossa. So medial and lateral views. So keep in mind that the ulna is on the lateral side and the radius, the ulna is on the medial side, medial, ulna on the medial, and then the radius is on the lateral side. But you can still see part of the ulna on the lateral side because the radius sits a little bit anteriorly to the ulna. So keep that in mind when we look at other parts of the anatomy later. The humeral ulnar joint, we have the trochlea, which is oriented obliquely. The medial aspect projects more distally, creating this carrying angle. The joint surface. So if we look at the trochlea of the humerus, it's convex in the anterior-posterior direction, and it's concave in the medial lateral direction. So if we're talking about the humerus, it is more convex in the AP, and it is more concave in the medial lateral. Keep in mind, though, when we talk about mobilizing, we tend to talk about mobilizing the distal bone on the proximal bone. So in which case, think of your ulna and your radius, because your ulnar side is going to be in the AP direction concave, but it's going to be in the medial lateral direction convex. So it'll be the opposite of the humerus, whereas the proximal surface of the radius is going to be concave all the way around. So again, this is just so you can see a little bit how the surfaces, the medial side projects further than the lateral side. Anteriorly, the trochlear groove here is more vertical, and posteriorly it's more oblique. So again, think of this when we talk about our mobilizations, but also with respects to what movements will go together. So the groove results in a conjunct swing of the ulna. So in abduction, we're going to go more into extension, and with adduction, more into flexion, because we have this happening, and so it's going not in a complete frontal plane, but it's going to be going more at an oblique like this. So it's an angled frontal axis, So which will give an abduction with extension and an adduction with flexion. Again, the articular surfaces, like we said, is the capitulum. If we're looking at the humeral radial joint, is convex, and the radial head is concave all around. The radial ulnar joint, we have the radial head, which is convex all the way around, and the ulnar notch of the ulnar notch for the radius on the ulna. So that's an error there, is going to be concave to accept the head of the radius. The joint capsule is broad and thin anteriorly and attaches above to the medial epicondyle and to the humerus immediately above the coronoid and the radial fossa. The attachments below is the coronoid process and the annular ligament, and it's continuous with the radial and ulnar ligaments. In the anterior muscle, it's continuous with the brachialis. Posteriorly, it's thin. The attachment's above the humerus. It's behind the capitulum and close to the lateral margin of the trochlea, the rim of the olecranon fossa, the back of the medial condyle, upper and lateral margins of the olecranon, and continuous with the capsule of the superior radio-ulnar joint deep to the annular ligament. As we said, all three joints are in the same capsule. And the posterior part is related to the triceps and the anconeus. So this is just an example in the posterior part here. You can see the anterior part coming down, and here's the annular ligament. So this capsule insertion extends distal to the annular ligament. There's also a synovial fold at the humeral radial joint that's just proximal to the border of the annular ligament. And also it's bound, the synovium is bound to the common extensor tendon. So you can imagine how that might play a role in a pathology if we could create a synovial irritation in that area. And elbow joint capsules, or joints capsule, because it englobes all three of the joints. Thank you.